And I'd love to ask, are there any features, pathologic features, for example, that might sway you more towards using T-DXd versus T-DM1 in the adjuvant setting, whether that's hormone receptor positive status or negative, BRCA status, anything of that nature, that grade, KI, anything that may sway you towards use of T-DXd versus T-DM1? And I'll apply that question also to the neoadjuvant setting. I'm curious.
I would say more with pathology. I mean, definitely if patients have positive nodes after neoadjuvant chemotherapy, I think that would be a patient that would definitely want to see a T-DM1, T-DXd versus T-DM1. If it's minimal residual disease in the breast, you could argue both ways. Although still those patients, because those patients may not have been included anyways. I mean, now if they were positive before and the nodes became negative, but there's still residual disease in the breast, that's where you may have a little bit of leeway. But I want to make the other point that also we need to educate the surgeons on this, on the ILD, because oncologists know very well this drug, but surgeons don't have the nuance of knowing all that. So I think because we see the patients also meet chemo, we talk to them and get them ready for surgery. So it'd be nice to know if they have any symptoms. You know, sometimes patients say, "Oh, I had surgery. I'll have surgery in 2 weeks, but I have a little cough." And the surgeon say, "Okay, it's probably okay. It's okay. If you feel better or something, we'll do the surgery or something." So it's important to know. Similar to, for example, triple-negative breast cancer, how we try to identify some of the checkpoint inhibitor immune-related toxicities.
100%. No,
people may not be aware of this.
You point out such a critical piece of this is that we all work together. Radiation oncologists, medical oncologists, surgeons, we're all one team and taking care of our patients. And so what is any strategies a surgeon may use to be able to keep up with this fast-paced data that's coming?
I mean, I think hopefully the surgeons that work in multidisciplinary setting, I think with tumor boards, with multidisciplinary clinic appointments, we do a lot of those. We communicate with each other. And I think it's up to the oncologists then to educate us on that, to know what to look for. Because again, most surgeons may not even know that, even if they know about this drug.
Absolutely.
So education is key.
And I think you bring up another important point just in terms of that multidisciplinary approach and making sure everybody's on the same team. That infrastructure has to be in place, right? And that sometimes is challenging in the community setting, right? It's not that our community oncologists are any less thoughtful. It's just that sometimes that infrastructure is maybe not in place, and that is a huge burden for them to, for example, get a pulmonologist appointment very quickly or get a high-resolution chest CT done at a specific time. So these are real practical challenges that we're going to have to work through, but I think it's effort well spent because this therapy is clearly very effective for our patients, our high-risk patients.